Right now, like at this very second, your blood is performing this incredibly high-stakes tightrope walk.
Oh, absolutely. It's constant.
Yeah, and if its chemistry changes by, even 1/10 of a decimal point,
hmm
the emergency medications designed to save your life could just become entirely useless.
It's a terrifying thought, but yeah, it's true.
You might have the best doctors in the world, right, just pumping you full of these life-saving drugs. But if the actual fluid touching your cells is hostile, well, those drugs simply won't work.
They won't. They just bounce right off.
Exactly. So welcome to this deep dive. Today, we have a really fascinating stack of sources to go through.
We do, yeah. It's essentially a collection of comprehensive clinical guides, like the cheat sheets used by critical care professionals.
Right, and our mission here is to decode the secret language of your blood, specifically this thing called an arterial blood gas, or an ABG.
Hmm.
We're going to figure out how the human body manages this, incredible balancing act every single minute.
It's such a vital language to learn, too, because when you first look at an ABG printout, it genuinely looks like alphabet soup.
Oh, totally. Just letters and numbers everywhere.
Yeah, you see PaO2, PaO2, HCO3, and just a scatter of numbers. But for a clinician, those numbers aren't just, data points.
Right, they tell a story.
Exactly. They are a real-time window into how well a patient's fundamental life support systems are holding up under immense pressure.
Okay, so let's unpack this. We need to set the scene first. What actually is an ABG? When I go to the doctor for a physical, they usually stick a needle into the crook of my arm.
Yeah.
To draw blood. Is this the same test?
No. It's quite different, actually. The blood you're used to having drawn is venous blood.
Venous, like from a vein.
Right. That's blood that has already traveled all the way through your body, delivered its payload of oxygen to your tissues, picked up the waste, and is heading back to the heart.
So it's basically the exhaust.
Yeah, it's a good way to put it. An ABG, as the name implies, is drawn from an artery. Usually it's the radial artery right in your wrist.
Ouch.
That sounds...
Yeah, it's deeper. And this is blood that has just left the lungs, so it is freshly oxygenated and on its way out to the body.
Okay, got it.
Clinicians use this specific fresh blood to measure two absolutely critical things: oxygenation and acid-base balance, which, we measure as pH.
And reading through these clinical guides, they make it very clear that this isn't just a casual procedure. It's a more painful draw for the patient, like we said. So a doctor isn't ordering an ABG just to check your cholesterol.
No, absolutely not. There are very specific, pretty alarming clinical triggers that prompt this.
Right.
You are generally looking at a patient who is in acute distress. The sources highlight a few major red flags for this.
Like what?
Well, one is a sudden change in their level of consciousness, what we in the medical field call LOC.
Okay, LOC.
Yeah, if a patient is suddenly deeply confused or, lethargic and impossible to wake up, that's a huge trigger.
Wow. Another is increasing respiratory difficulty, where you can literally physically see them fighting for every single breath. Or they might have a dangerously low blood pressure.
Like how low?
Maybe a systolic reading down in the 70s or 80s. When a patient is crashing like that, the ABG tells the medical team if the blood is actively turning toxic to the patient's own organs.
Man, that is intense. But there is a massive caveat in the text that we should probably establish right up front. The ABG is really just a snapshot, right?
Precisely. It is one fraction of a second in a highly dynamic chemical process.
Because things are changing so fast.
Right. You can never treat just the piece of paper. The numbers are totally useless if you don't contextualize them with what the patient actually looks like lying in that hospital bed.
Because the chemistry is constantly shifting. And that brings us to the core tension of this entire system. I was looking at the normal values for human blood, and the margins are shockingly narrow.
They really are.
Yeah, if we think about the body as a house, I kind of picture the pH level as like the thermostat, set to this incredibly strict Goldilocks zone.
That's a helpful starting point, but I'd actually adjust the analogy just a bit based on the physiology.
Oh, really? How so?
Well, the pH isn't the thermostat. The pH is the actual temperature of the room.
Oh, I see.
Yeah. The lungs and the kidneys are the massive HVAC systems working tirelessly to keep that temperature from fluctuating. And that Goldilocks zone for blood pH is incredibly strict. Normal is between 7.35 and 7.45.
That is tiny, just a tenth of a point.
Exactly. Anything below 7.35 is acidosis, which means too much acid. Anything above 7.45 is alkalosis, so too much base.
So to keep the temperature in that tiny 7.35 to 7.45 window, the body relies on those two main regulators. Let's look at the first one, the respiratory system. your lungs.
Right, the lungs.
Our sources describe this as the fast-acting system, like it can make chemical adjustments in a matter of minutes.
It does that by controlling the level of carbon dioxide, or PaCO2, in your arterial blood. And there is a fundamental rule in the source material that every listener needs to lock in right now to understand how this works.
I know exactly what you're going to say.
Oh, you do? Well, it's that on the ABG, PaCO2 is an acid.
Carbon dioxide is an acid. I literally circled that 3 times in my notes.
It's the absolute key to the respiratory half of the puzzle. The normal range for PaCO2 is 35 to 45 millimeters of mercury.
Okay, 35 to 45.
Right. So if your lungs hypoventilate, meaning you hold on to carbon dioxide, your blood rapidly becomes more acidic.
Because you're holding in the acid.
Exactly. And conversely, if you hyperventilate and blow off too much carbon dioxide, your blood loses acid and shifts toward alkalosis.
So the lungs are like opening or closing a window. It's a fast, immediate change to the room's environment. But what about the heavy machinery? The slow response?
That would be the renal system.
Yeah.
Your kidneys. They are the true heavy lifters of acid-base balance, but they are slow.
Like how slow?
It takes hours or even days for them to fully ramp up. The kidneys regulate the metabolic side of the equation by controlling bicarbonate.
Which is noted as HCO3, right?
Yes, HCO3.
And bicarbonate is essentially a chemical buffer. It's a base that neutralizes acids.
Correct. The normal range for bicarbonate is 22 to 26 milliequivalents per liter, though one of our clinical sources extends that normal upper limit to 28.
Okay, so 22 to 26,
Yeah.
maybe 28.
Yeah. So the lungs manage the volatile acid, and the kidneys manufacture and excrete the base to keep everything perfectly countered.
But here's the question I kept returning to while reading all this. Let's say the pH drops a tiny bit. It goes down to like 7.2.
Okay, 7.2.
In the grand scheme of numbers, 7.2 isn't that far from 7.35. Why does the body panic so much? What is the actual physical danger to the patient?
Well, what's fascinating here is the sheer mechanical reality of biology. The sources actually feature a practice alert about the cascading failure this causes.
A cascading failure.
Yeah. Proteins in your body, including the receptors on your cells and the enzymes that run your metabolism, they have very specific folded shapes.
Right.
And those shapes are maintained by the surrounding pH. So when the blood falls out of that 7.35 to 7.45 range, the acid or base physically warps those proteins. They change shape.
Oh, wow. Which brings us back to the scenario at the very beginning of our deep dive, the medications.
Right. It's a double whammy for the patient. A drug works like a key fitting into a lock on a cell. If an acidic environment changes the shape of the lock, well, the key no longer fits.
That makes perfect sense.
So a nurse might be pushing powerful, life-saving drugs through an IV to stabilize a crashing patient's heart rate or blood pressure. And those drugs are doing absolutely nothing.
Because the locks are warped.
Exactly. The acidic environment has completely neutralized them.
That is terrifying. I mean, it makes total sense why clinicians are so aggressive about balancing pH. But you can't fix the pH if the tissues themselves are suffocating.
No, you definitely can't.
We need to talk about the other massive component of the ABG test, oxygen. Here's where it gets really interesting, because measuring oxygen isn't just a matter of checking a fuel gauge.
Far from it. The ABG provides 2 distinct measurements for oxygen, and clinicians absolutely need both to grasp the whole picture.
What's the first one?
The first is PA2, which stands for the partial pressure of oxygen. Think of this as the oxygen that is dissolved freely in the blood plasma itself. The normal range is 80 to 100 millimeters of mercury.
Okay, so if oxygen is a physical cargo, the PO2 is the raw supply sitting in the warehouse just waiting to be picked up.
That's a great analogy.
And that leads to the second measurement, right? The SO2, the oxygen saturation.
Right. The SA2 measures the percentage of oxygen that has actually attached itself to hemoglobin molecules inside your red blood cells. Normal saturation is anything greater than 95%.
So building on that cargo idea, if hemoglobin is a fleet of delivery trucks, the SaO2 tells us what percentage of those trucks are fully loaded with oxygen and driving around the bloodstream.
Yes, that's exactly how to visualize it. But the text introduces a brilliant physiological twist here called the oxyhemoglobin dissociation curve.
A mouthful, buddy.
Because loading the trucks at the lungs is only half the job. The real trick is that the trucks have to know exactly when and where to unload that cargo to the starving tissues.
Right?
And they make that decision based almost entirely on the acid-base environment we were just talking about.
This blew my mind. The affinity, the actual physical grip that the hemoglobin has on the oxygen molecule, it changes depending on the pH.
It does.
The sources describe this as a shift to the right or a shift to the left. Let's break down the shift to the right, because on the surface, it sounds completely counterintuitive.
It does sound weird at first. A shift to the right happens when the body is in an acidotic state. When the blood becomes more acidic, it causes a slight structural change in the hemoglobin.
Like the warping locks.
Exactly. And as a result, the red blood cells experience a decreased affinity for oxygen. They literally lose their grip on it. They unload the oxygen much more fiercely to the surrounding tissues.
So the delivery trucks sense the acidic environment, and they just start throwing the oxygen cargo out the doors to the cells.
Yes, and the clinical application of this mechanism is remarkable. The text notes that critical care doctors might actually purposely allow a patient to remain mildly acidotic for a period of time.
Wait, really? On purpose?
On purpose. Why? Because if the patient's tissues are desperately starving for oxygen, that mild acidity forces the red blood cells to dump more oxygen exactly where it's needed. The acidity actually improves oxygen delivery.
You're using the hostile environment to force the body to feed itself.
Mm.
That is wild. But what happens if the chemistry swings the other way? What if the patient is alkalotic?
That causes a shift to the left. In an alkalotic state where there's too much base and not enough acid, the hemoglobin gets incredibly stingy.
Stingy trucks.
Very stingy. It develops a high affinity for oxygen. So the delivery trucks pull up to the tissues that need oxygen, but the doors are locked. The red blood cells just refuse to let go.
So a patient could be sitting there with an SO2 of 100%, like every single truck is fully loaded, but their tissues are still suffocating because the oxygen won't detach from the hemoglobin.
Exactly. The supply is there, but the delivery fails completely.
Wow, it's an incredible piece of biological engineering. Before we get into how these specific systems break down, the text had two surprising facts about oxygen I want to bring up.
Oh, sure.
First, what we consider normal oxygen actually changes as we age.
It does. As we get older, natural changes in lung elasticity mean we just don't process oxygen quite as efficiently.
That makes sense.
The source provides a quick formula for clinicians.
Hmm.
For a patient over 60, you subtract 1 point from the lower limit of 80 for every year over 60.
Okay, let me do the math.
So for an 80-year-old patient, a normal, healthy PaO2 might naturally sit at 60 millimeters of mercury.
Because they're 20 years over 60, so 80 minus 20 is 60. Got it. And the second fact was about how much oxygen we actually use. Normally, as blood circulates, our tissues only extract about 25% of the available oxygen.
Right. The rest is kept as a massive reserve.
But if you have a fever, a severe infection, or you're in intense pain, your metabolic demand skyrockets. Your body starts pulling way more than 25%.
Yes, it gets greedy.
And doctors can actually measure what's left over the venous oxygen, or SVO2, from the right side of the heart to see how hard your body is working to survive.
It all comes back to that delicate balance, supply, demand, and the chemical environment dictating all the rules.
But what happens when those fail-safe mechanisms break down? The sources outline 4 primary states of chaos, 4 specific ways this system collapses.
Let's get into it.
Let's start with the lungs. Respiratory acidosis.
Right. In respiratory acidosis, the blood pH is dangerously low, it's acidic, and the culprit is the respiratory system. The PaSO2 is greater than 45.
Meaning the patient is holding on to carbon dioxide.
Mechanically, this is hypoventilation. They are simply not breathing deeply or fast enough to clear the exhaust out of their system.
The text lists causes like an opioid overdose, a severe head injury, or chronic diseases like COPD. Basically, anything that suppresses the brain's drive to breathe or physically obstructs the airway.
Right.
But what does that actually do to the patient's body? What does it look like?
Well, early on, as the CO2 begins to rise, the patient might experience a headache or flushed skin. But CO2 easily crosses the blood-brain barrier.
Oh, that's not good.
No. As it builds up to toxic levels, it depresses the central nervous system. Those are the late signs.
Yeah.
Lethargy, severe confusion, somnolence, they become impossible to keep awake.
So how do you treat it?
The treatment concept is straightforward. You have to help them breathe more. You administer Narcan to reverse an opioid overdose, you use a BiPAP machine to push air in, or you intubate them and let a ventilator mechanically blow off that carbon dioxide.
Okay, let's look at the opposite respiratory problem. Respiratory alkalosis, high pH, low CO2. This is hyperventilation. The body's blowing off way too much acid.
The classic triggers here are severe anxiety or panic attacks, intense pain, or even the very early stages of an asthma attack where the patient is breathing incredibly fast out of distress. They are dumping CO2 faster than the body can make it.
I noticed the symptoms for this one are weirdly specific. The sources mention tingling in the extremities and tetany, which is like severe involuntary muscle cramping.
Yes.
Why does a lack of acid cause your muscles to cramp?
It comes back to the chemistry again. When you blow off too much acid, your blood becomes alkaline. That alkaline environment causes calcium in your blood to bind much more fiercely to proteins like albumin.
Okay.
So suddenly you don't have enough free-floating ionized calcium in your bloodstream. And free calcium is what stabilizes your nerve cells.
Oh, I see.
Without it, the nerves become hyperexcitable. They misfire, sending constant signals to your muscles to contract. That's why the patient gets that tingling and those intense involuntary cramps.
To fix that, you just have to treat the root cause, right? Calm the panic, treat the pain, or if they are on a ventilator, literally turn the machine's breathing rate down so they hold on to some of that acid.
Correct. You just have to stop the hyperventilation.
So that's the fast system. Let's look at the slow system, the kidneys. Metabolic acidosis. This is a low pH and a low bicarbonate.
Right.
The base buffer is gone, or a massive amount of new non-respiratory acid has flooded the system.
This is a very common scenario in critical care. Causes include diabetic ketoacidosis, where a lack of insulin forces the body to burn fat, producing toxic acids called ketones.
Wow.
Sepsis is another major cause, where massive infection causes lactic acid to build up. Or renal failure, where the kidneys literally just stop filtering hydrogen ions out into the urine. You can also lose your base buffer directly through severe diarrhea.
There was a specific symptom listed here that I found fascinating. Kussmaul respirations.
Oh, yes. Very distinct.
When a patient is in severe metabolic acidosis, their breathing pattern shifts to these very deep, rapid, labored breaths.
It's the lungs trying to act as a backup generator.
Exactly. The metabolic system is failing and the blood is becoming highly acidic. Chemoreceptors in the body sense this toxic acid level and send a panic signal to the brain.
Telling the lungs to wake up.
Right. The respiratory system realizes it needs to pitch in immediately. So, Kussmaul respirations are the lungs desperately hyperventilating, trying to blow off as much volatile CO2 acid as possible to compensate for the metabolic acid that the kidneys can't handle.
The fast system is covering for the slow system. Which brings us to the final state. Metabolic alkalosis, high pH, high bicarb.
Yes.
Now, I had a moment of confusion reading this. I thought, wait, if severe diarrhea causes you to lose base and become acidotic, how do we lose acid to become alkalotic?
You have to look at where the fluid is being lost from.
Okay.
The fluid in your lower GI tract is rich in bicarbonate. It's a base. So losing that fluid via diarrhea causes acidosis.
Yeah.
But the fluid in your stomach is hydrochloric acid. Ooh, right.
So if a patient is experiencing excessive vomiting, or if a nurse is performing constant gastric suctioning through a tube in their stomach, they're literally pumping pure acid out of the body. Diuretics are another major culprit, forcing the kidneys to excrete too many hydrogen ions into the urine.
And the symptoms look a lot like respiratory alkalosis, dizziness, muscle cramps from that calcium binding issue we talked about, eventually leading to severe lethargy. And the treatment is just to plug the leak.
Precisely. Stop the suctioning, give them antiemetics to stop the vomiting. You remove the source of the loss and give the kidneys time to catch up.
Okay, so we know the 4 ways the system breaks. Now we get to step into the ER.
The fun part.
The sources lay out a methodology for actually reading the ABG printout. Let's picture a patient rolling through the ER doors, crashing. The doctor gets this ABG slip. They don't just read it top to bottom like a receipt, do they? Step 1 surprised me.
No, they definitely don't read it sequentially. They operate on pure survival instinct first. Step 1 is always, look at the oxygen.
Oxygen first.
Always. The acid-base puzzle is elegant, but a lack of oxygen is an immediate minutes-to-brain death threat. A clinician looks directly at the PO2. If it's indicating severe hypoxemia, meaning it's dropped between 20 and 49 millimeters of mercury, the clinical guide literally says, move fast.
Don't do math, just move.
Right. You don't sit there calculating bicarb levels. You anticipate immediate intubation.
Survive first, solve the chemistry later. Okay, assuming the oxygen isn't at a disaster level, the doctor moves to step 2, analyzing the pH. And the text introduces something called the lean method, which is vital for finding the culprit.
Let's look at how the lean method works. Imagine the patient's pH comes back at 7.38.
Okay, 7.38.
Well, the normal range is 7.35 to 7.45. So 7.38 is technically categorized as normal.
Right.
But 7.40 is the exact true neutral middle. Therefore, 7.38 is normal, but it leans acidotic. It's sitting on the acidic half of the normal scale.
Ah, I see.
Conversely, 7.43 is normal, but it leans alkalotic. You must establish that lean before you move to the next step.
Because that lean tells you what the primary problem used to be, or still is, before the body started fighting back, which leads right into hunting down the guilty organ in steps 3 and 4.
Right. Once you establish if the pH is acidotic, alkalotic, or leaning one way or the other, you look at the para-2 and the HCO3. You are looking for a match.
A match.
Whichever value mathematically matches the state of the pH is your primary problem.
Okay, let me try one. So if my patient's pH is 7.25, that is undeniably acidotic. I look at their CO2 and it's 55, which is high. We remember our golden rule. CO2 is an acid.
Exactly.
So the CO2 is acidotic and matches the pH. Boom. It's a respiratory problem. The lungs are the culprit.
You've got it perfectly. And if you check the bicarb and it was abnormally low, meaning there wasn't enough base MAC, then the bicarb would be the acidotic factor matching the pH, making it a metabolic problem.
But what if they both match? What if the pH is 7.1, incredibly acidotic? The CO2 is 60 tons of respiratory acid, and the bicarb is 15, a severe lack of metabolic base. Both the lungs and the kidneys are driving the body toward acid.
That is a mixed acid-base balance, and it is a nightmare scenario for a clinician.
I can imagine.
You have a respiratory acidosis A and D, a metabolic acidosis happening simultaneously. The patient's systems are failing on multiple fronts at the exact same time.
Okay, so assuming it's not a mixed nightmare, we've identified the single culprit. The final step, step 5, is assessing compensation. This is where we look to see if the body's magnificent fail-safes are actually working.
If we connect this to the bigger picture, compensation relies entirely on a specific, elegant chemical equation happening in your blood right now.
Let's hear it.
It goes like this. Carbon dioxide plus water yields carbonic acid, which then breaks down into a hydrogen ion and a bicarbonate ion.
Okay.
CO2 plus H2O yields H2CO3 yields H plus HCO3 minus.
And it has arrows pointing in both directions. It's like a seesaw.
Exactly. Because it's reversible, the lungs and the kidneys are chemically chained together. When one system breaks, the other system uses this equation to alter its own chemical levels, pulling the pH back into the safe zone. We measure how successful this is in 3 stages: uncompensated, partially compensated, and fully compensated.
Let's trace that with a patient. Uncompensated seems pretty straightforward.
It is. Let's say your patient has respiratory acidosis. Their CO2 is sky high and their pH is deeply acidic. But you look at the kidneys, the bicarbonate level, and it's sitting perfectly normal at 24.
So it hasn't even reacted yet.
Right. The opposite system hasn't started helping yet. It's uncompensated.
The kidneys haven't turned the furnace on yet. But let's say we check back in a day later. The CO2 is still high. The pH is still acidic. But suddenly, the bicarbonate has jumped to 32. It's way out of its normal range, churning out tons of base to fight the acid.
That is partially compensated. The opposite system is actively trying. It is moving outside its normal limits, but it hasn't yet successfully pulled the pH back across the 7.35 line into the safe zone.
And then finally, fully compensated.
Fully compensated is when the opposite system has worked so intensely and produced so much of its opposing buffer that the pH is finally dragged back into that 7.35 to 7.45 window.
So the patient is stable.
In a way, when you look at a fully compensated ABG, the pH will read as normal, but both the CO2 and the bicarb will be wildly abnormal.
And this is exactly why the lean method from step 2 is so critical. If the pH is 7.36, it looks fine, but it leans acid. So, the original primary problem was acidotic, even though the body's backup generators managed to drag the pH back over the finish line.
You're not just reading numbers, you're reading the chemical history of a battle for survival that just took place inside the bloodstream.
Man, so when we step back from the massive web of normal ranges and the shifts in hemoglobin and the Kussmaul respirations, what we are really looking at with an ABG isn't a clinical chore. It is a real-time narrative.
It really is.
It's the story of a desperate, invisible dance between your lungs pulling in air, your kidneys filtering waste, and your red blood cells acting as the ultimate logistics network, all conspiring to keep your cellular environment perfectly stable.
And that is exactly why this material matters to you, whether you are a medical student prepping for your clinical rotations or just someone fascinated by human biology. Once you understand the mechanics of this system, you can't look at a simple breath the same way again.
Definitely not.
Every single time you exhale, you aren't just expelling waste gas, you are performing a highly precise act of chemical balancing. You are literally adjusting your own internal pH.
It really is a profound, minute-by-minute tightrope walk. But I want to leave you with a final thought to ponder. Building on something we touched on just a bit earlier, we spent a lot of time exploring the beauty of compensation.
Right.
How the chemical equation allows the lungs to cover for the kidneys and the kidneys to cover for the lungs. But think about that mixed acid-base balance scenario we mentioned.
The nightmare scenario.
Yeah. What happens when a patient presents with an acidic CO2 from failing lungs and an acidic bicarb from failing kidneys at the exact same time?
It's a grim picture.
When both the respiratory and metabolic systems fail and become the primary problem simultaneously, where does the body even begin to find the buffer to save itself? When the tightrope snaps and the safety net is completely gone, what happens next?
That raises a very important question indeed.
Something to mull over until next time. Keep asking questions and keep exploring the deep dive.